So welcome back to our third and final keynote speaker. Very delighted to have you here, Dr. Alan Taylor. Dr. Alan Taylor is Vice President for Research at the Center for Health Design in the United States. The Center for Health Design, for those who don't know it, is a nonprofit which was founded around 30 years ago, and since then has been advancing the use of evidence-based design process to improve health, safety, and business outcomes. So you could compare it to what we are trying to build here. So for us, it's really very exciting to have you here and to learn from your experience and to get in contact with the Center for Health Design. Dr. Alan Taylor is an architect with a PhD in design, patient safety, and human factors. She also has MBA degrees from Columbia University and the London Business School. Alan was president of the Academy of Architecture for Health and currently serves as the vice chair for the Health Guidelines Revisions Committee of the Facility Guidelines Institute. Alan, this is very exciting, is the co-director of the Health Environment Research and Design Journal called HERD, some of you might know it, and an editorial advisory board member of the American Journal of Infection Control. Please welcome Dr. Alan Taylor.
Thank you so much. It's really wonderful to be here, and I really enjoyed this morning's presentations, and I think this will be a little bit different and hopefully tie some things together as well. So the title of the presentation, Where We Were and Where We're Going, is really, I think, grounded in a couple of key points. And one is that this really starts to look at work that the center started doing about a decade ago. So it was mentioned the Facility Guidelines Institute. The Facility Guidelines Institute in the United States is a body that creates guidelines and standards for the design of healthcare facilities and is adopted as code in most states. So it says guidelines, but it actually becomes a code, and it's focused on minimum standards. And back in 2014, it's on a 4-year cycle, I should mention. So the 2018 guidelines start development in 2014, 2015. Right now, we're in the process of developing the 2026 guidelines. There's a long runway. And what we started looking at was the advances in telemedicine. And there were some very philosophical discussions about this in the context of it's just about the technology, it's not about the environment. But if we start to look at telemedicine, it has really evolved for many, many years at this point, not just the past 10 or 20 years. These images actually go back 100 years. So if you look at the image on the left, you have the radio doctor, maybe, but take a look at that. It's got a screen, it's got a printout, it's got a speaker. It has all of the things that we associate with telemedicine today, and this was envisioned 100 years ago. If we look at the image on the right, we actually have the advance of the Da Vinci robotic surgery, because you have the physician with his peripherals reaching into the patient who's lying in the bed, healthcare at home. So these aren't new ideas, and yet we tend to think of them as being new because of the advances in technology that have been happening more recently. So again, if we look at this, it even goes back more than 100 years. We start to look at the evolution of all of the different telas. So you have the telegraph, you have the telephone, you have the television, and then you have telemedicine. And where all of this starts to fit in is where all of these technologies start to come together, and you really start to see the government in the United States really trying to leverage the technologies and providing remote care and looking at these different issues in terms of space travel, for example. How do you care for people when they're not even on the planet? And really trying to understand, what are some of the implications? And of course, COVID happens and everything starts to shift very quickly. And a lot of that wasn't just the technology, it was the regulatory models, the reimbursement models, what people suddenly allowed because we weren't allowed to be within those physical spaces anymore. And part of what people have been talking about since then is there was a huge spike in the use of telemedicine, and then it dropped off fairly quickly after we were all allowed back in spaces together. And why is that? I think people are still trying to figure that out. What are some of the implications? But this presentation is actually going to focus on the specifics around the built environment and really focusing on what I mentioned earlier, this concept of minimum standards associated with telemedical care and the implications for the built environment. So I mentioned philosophical discussions. Many organizations saying telemedicine doesn't have anything to do with the built environment. It's just about the technology. I can buy the best technology and it will take care of all of those other issues for me. Equity, inequity. So one of the organizations that was saying this during these discussions was from the Mayo Clinic. And they said, well, if we get it wrong, then we just build another one. That's wonderful if you're the Mayo Clinic and you can afford to do that. But most organizations don't have that flexibility. They need to get it right the first time. So what are the things that we really need to think about? So we developed what we considered minimum standards. There were really just references to the different considerations that I'll talk about today. And then most of the language was in guidance language, so not required, just helpful suggestions in terms of how that might get done. And it evolved into an issue brief that we released in 2020 with the advent of COVID to really say, hey, there's a lot of stuff that we've already learned about this. What are the things that we've learned in the past 4 or 5 years, and how does that translate into how we're delivering care today? So a lot of what I'm going to talk about today is based on that evolution of the past 10 years, even though this has been going on for so much longer. So there's different, sorry, I can't move. There's different definitions that can be used between telepresence, telehealth, and telemedicine. And again, we had these discussions when we were speaking together at FGI. What do we actually mean when we're talking about telemedicine? How do we define that? And we actually had to come up with our own definition to try and provide some clarity around this. But I really like this definition from 2017. This is from a paper from the American Telemedical Association, the Human Factors Group, which is really recognizing telemedicine as a system. It is a complex system that has many different components. Again, it's not just about the technology. And some of the things that they said is it's independent of the clinical context and the content. There are a lot of other things that are happening aside from the exact diagnosis or treatment that's happening. It really takes into account the demeanor of the participants, the quality of your encounter. So what can we do to improve all of that? And my favorite part of this definition is it's everything that technology can convey. The lighting, sound, noise, room appearance. In my world, that's the built environment. So immediately we have a definition that is coming about that really talks about the importance of the built environment and how it is an integral part of the system. Now, one of the things that we talked about in terms of our own definition, telehealth being more broad and telemedicine being more of that direct interaction between the patient and the clinician. And part of what we were talking about is this is not the teledoc or doc in a box where, I'm not feeling well, I have a headache, I want to speak to my doctor. We're really talking about when there is a physical presence of somebody required for a specialty, a medical specialty, or for a presentation of a patient. So it's really making sure that we have the space to be able to provide that service. And that means we need to understand what types of services are being provided. And one of the things that we decided as a minimum standard for FGI was that if you're going to provide telemedicine services, you need to have a room in which to provide that service. It sounds very basic. It doesn't have to be the only thing you do in that room. You can do other things in that room. But part of what we were hearing from people was, well, the doctor is just off in the hallway in the emergency department having a telemedicine consult. There is no privacy. There's discombobulation, there's confusion, there's lots of other things that are happening. So we said, let's make sure that there's a space. And then within that space, let's make sure that the space is actually large enough to provide those services that may be needed. So you typically have some type of a cart that has the camera, that has a microphone system, that has the place that you're going to view either the clinician or what the clinician is seeing. You need to have an exam table so that somebody can actually be examined. There's typically a presenter that happens with that person that is either directing the person what to do or responding to the clinician to help them understand more of the specifics about what's happening. And then an area for documentation. And depending upon what type of procedures are being offered, we also say you need to have a hand hygiene sink. If you have to have a hand hygiene sink for a regular hands-on examination, you still may have a partial hands-on examination with the presenter and the patient. So depending upon the types of services, you may need that as well. So privacy, I mentioned that in terms of physicians, clinicians that were perhaps conducting telemedicine visits, telehealth visits in public spaces, even if they're in a healthcare setting. So we really start to look at privacy on a couple of different fronts. It's not just that audio privacy, it's also the visual privacy. It's being able to understand what are the things that are happening around you and how does that help or hinder that actual transaction. So we tend to think of people thinking about telemedicine as being a healthcare encounter, and yet this is a quote from a presentation at HIMSS in 2016. Never ever think that you can perform a consult in a public space like Starbucks, McDonald's, or Panera Bread, which I think here would be similar to Pret-a-Manger. I mean, just the concept that this even has to be stated is remarkable. And yet, somehow we think of telemedicine as being different in terms of privacy than we think about it being in that in-person encounter. And we need to shift that paradigm. We need to help people understand just because it's remote, just because it's digital, doesn't mean we don't think about these other components. So there was a study that was done in 2024, published in 2024, and the title, I think, is interesting. When the visible body is no longer the seer, the phenomenology of perception and clinical gaze in video consultations. And one of the things that they really found is they were talking to providers about what they experienced with patients during COVID and the rise of telemedicine services. And the physicians were, so we've just talked about the physicians being not so careful about where they were providing these services, but the physicians were saying, yeah, I've had patients that call in from supermarkets, from public transportation, from their car. I really like the last one, the office toilet. I think that's the effort to go and find a private space where you're not around your colleagues, so I'll go into the stall. Maybe we need to design a better toilet stall if that's how we're going to do things. But then there are some unintended consequences. So we talked this morning about the presence of family, the presence of other people that may need to be involved in that decision making. And sometimes what ends up happening is because of that remote care, you don't have the people that you need to be there. Maybe the family member isn't there because you're in your office bathroom stall. But maybe sometimes the family member is there, and that also creates a set of challenges because there's been research to show that as a patient, I may not be as forthcoming with my information if I know that my family members are hearing me. And I may not want to share what I'm really feeling because I don't want to create any stress and anxiety with my family members. So again, how are we creating different types of spaces for people to really get the care that they need? So we also have the issues of it is incredibly convenient and flexible for both the clinicians and the patients, but it comes at the expense of potentially safety and confidentiality. So always trade-offs. This is the challenge in healthcare, is that we always need to figure out what are we giving up for the benefit of something else. But the primary comment that really came out of this study that I thought was interesting was clinicians felt like we lost control of that protected space. Now we have these porous spaces that we have very little control over, and we really aren't entirely sure how to manage this all of the time. So we can have real visual and audio privacy. We can also have perceived audio and visual privacy. So these are some pictures from a presentation that I did in 2020 in the midst of COVID. And it's really interesting because a lot of what we think is sort of standard now came out of our own personal experiences of COVID. So previously, I mentioned that quote from 2016, don't provide telemedicine and McDonald's or a Panera Bread. Suddenly, we all became very concerned about how we looked on camera. We bought the ring lights, and we had all of these backgrounds, and we had stylists telling us what to put in our backgrounds to make us look better. Why weren't we thinking about this before? It's because it became very personal, and suddenly we understood some of the issues in a much different way. So the picture on the left was my home office at the time, and there's a door behind me when I had rotated my desk 90 degrees. Now, there's been research to look at this, and it creates some challenges because, first of all, you don't know who's behind the door. You don't know what's happening there. More so, you don't know who might open the door while you're in the middle of a conversation. So automatically, you have something that is being created that is a less than environment just because of the physical surrounding that you've created. So you can rotate the desk and you're not going to see that door. That shifts the perception of what's actually happening in that space. So I mentioned family overhearing. So how many of you during COVID and work from home were sharing space with another family member? Maybe you were in the kitchen, the family member was in the background. Maybe you'd have to tell the person, I'm going to be on a call. Can you please leave? How many people experienced that? Yes, I think we all did. So the other thing that I ended up hearing from a clinician was when he was doing his calls from home, as required, everybody else in the house was hearing his encounters with his patients. So not the best for patient privacy when you have everybody else in your family who's trying to work from home hearing what some of those transactions are. And then there's the issue of windows. So even if you're in a closed room, you can have, again, the perception of people walking back and forth and what kind of an environment am I in, and just really understanding what is your space conveying to the person on the other side of the line. It actually does matter. So acoustics and acoustical privacy. So sometimes what we're ending up talking about is the actual quality of the sound, but importantly, we're talking about what people can actually hear and understand. So the intelligibility of speech. And it seems pretty basic, but again, sometimes these things just need to be very explicit in terms of how they're stated. So making sure that you're providing care in a quiet environment, really making sure that the space around you isn't creating extra noise. So sometimes we don't have control over that. If you're in a home and there's traffic going by, you can't necessarily control that. There's things that you might be able to do. In other cases where maybe there's an HVAC system that is very loud when it goes off, you just might need to figure out, are there other ways that I can mitigate that noise? Is there another space where I might be able to do this? But even things like the room size and the room volume. So we tend to think of things as being, a certain ceiling height. A higher ceiling height is sometimes considered desirable in some types of built environment settings, but that can actually create reverberation. And that is not good for speech intelligibility. So we really need to think through the size and the height. So what is that total space really doing in terms of acoustics? The other thing is a lot of times architects think about wall systems and STC ratings, sound transmission ratings, or noise reduction coefficients. And the challenge is it's not just the wall, it's everything. It's the ceiling, it's the wall, it's the floors, it's any doors and windows that are in the system, and really understanding, do I need to put sound insulation into that wall to try and reduce the amount of noise that is being transmitted elsewhere? Has anybody ever been in an exam room where you hear what's happening in the exam room next to you? So we're trying to make sure that that doesn't happen so much where we can. There's other interesting information. There's been some controversy around some of these minimum standards in FGI, especially when it comes to acoustics, because it's a higher level of acoustics that is required in a telemedicine room. And we were just at a meeting with the entirety of the Health Guidelines Revisions Committee, and somebody asked somebody from the Acoustics Committee, I don't understand why it has to be a higher rating in a telemedicine room than in an exam room. That doesn't make any sense to me. And they said, what we found is that people speak about 30% louder when they're speaking into a camera. That is just human nature, so we need to, again, account for that within the space. If we know that people are going to speak louder, then what are we going to do with the space to try and, again, mitigate some of that? So is this the one instance where you think about carpet to try and deaden the sound? Do we use acoustical ceiling tile? Do we have soundproofing in the windows? What are the different things that we need to look at? We also need to understand that even with the technology, things happen. Microphones pick up the surrounding sound. It can be difficult for remote participants to hear. I think we've all been on calls where people are at different volume levels and you're trying to manage all of that. So again, it's not just the technology, it's really trying to figure out all of the different components and then how it fits together. So I mentioned the ring lights. So this is another important aspect of what we're doing, but it's not just about aesthetics. It's really about how we're using telemedicine as a diagnostic and through treatment. So what we're really trying to do is make sure that there's both direct and indirect lighting and make sure that the color rendition is actually correct. I love this photograph because this is actually a library in the United States. And this was a community that really decided, you know, people need a place to go, and we're going to provide this space that has all of the technology. So you'll see there's a separate microphone system, camera system, all of the very professional telemedicine types of lights, the background with the blue, which I'll talk about in a minute. So again, they really said, we're going to design a space with purpose for our community to be able to get the care that they need during this time. So why does it really matter beyond aesthetics? So first of all, we have issues of glare and contrast. So on the left is me at my desk with the light streaming in the morning, creating incredible glare. Or if I turn around and now the window is behind me, so now you really can't see anything at all. Even the best cameras have a really hard time adjusting for that kind of contrast because it's trying to find the happy middle. And as a result, it's not really finding anything. It's creating these very black and white type of situations. The color is also important, especially if you're looking at diagnostic issues. So this is just a difference between the type of lighting that's in the space. Maybe one I look a little less healthy than the other. So it depends, you know, if this is a dermatology visit, that probably matters. So again, we need to think about the type of lighting and what is that actually conveying when we're looking at somebody. So during COVID, how many of you use virtual backgrounds when you're on a Teams call or a Zoom call? Okay, prepare yourself. There's research on that. So there was actually a study that was done in 2022, and they called virtual backgrounds the new business suit because it creates perceptions. So let's talk about that. This isn't in healthcare, but I think it's pretty fascinating, and I'll talk about the results in a minute. But cameras in general have an easier time with blue. It is why you so often see telemedicine rooms with that light blue, medium blue kind of background. So in that library example, you saw that light blue. It ends up, if you use other colors, it tends to have the camera try to compensate and create that different coloring for the person that's in the room. So from a diagnostic perspective, this is the reason why blue is often chosen. So you can look at the differences here between a slightly bluish-white background, a background where there's other stuff that may be distracting. You know, again, other types of backgrounds where maybe contrast starts to become a problem. Obviously, it's all the same person, but you start to have different perceptions and things start to look a little bit different. So here's where that study comes in. The background actually influences perceptions of competence and trust. So we talk about building trust with technology. So here's a whole bunch of different virtual backgrounds. I think everybody in Zoom has probably seen that San Francisco Bridge in the upper left. Novelty backgrounds, not so good. You are not gaining a lot of trust and not projecting a lot of competence when you have a novelty kind of background. There's the standard sort of light blue, mottled blue, dark blue. There's one with the center's logo in the background. Those are okay, sort of those neutral backgrounds, fairly high levels of trust and competence are portrayed when people look at images like that. What played really well is bookcases, which I joked about during COVID. I'm like, what, does that make everybody think that you're smarter? Apparently it does. Apparently, if you have lots of books behind you, you're perceived as having a higher level of literacy. Therefore, you're more competent, and you should be trusted. Plants, also incredibly important. So plants and bookcases. If you're going to use a virtual background, those are your go-tos. This is what the research tells us. What fared the worst was the home. The home is not perceived well, not professional. You shouldn't be trusted. You're not competent. A blurred home is a little bit better, but we really need to think about, what is it, again, that we're portraying in the background. And Powell talked about, what is the concept of home? We have different homes, and we were talking at the break, what if you live in a trailer? There's all different kinds of things. So during COVID, there were lots of stories about clinicians saying, it's really great because I get to see the environment where my patient actually lives. But from a perspective of equity, that might not be the best thing, because now potentially you have a clinician who is in a very nice home and a patient that is maybe struggling to make ends meet. And now that power differential is back. And that's not necessarily something that we want to create. So again, just thinking through, what does that background tell us, whether it's a real background or it's a virtual background? But for all of you on Zoom, bookcases, plants. So the other consideration is around gaze angle. And gaze angle has to do with the relationship between the camera, where you're looking on the screen, and where your eyes actually are. So if I'm looking at the camera straight ahead, it is very far away. I can look at the camera. I have that direct gaze angle. If I start doing this, it's going to look like I'm not really paying attention to any of you, because I'm really focused on this presentation, and I'm really not feeling like I'm part of the conversation because I'm looking down at the laptop. And this study in the VA actually looked at what patients felt when their clinicians were not really participating with them in this encounter. And it's a challenge for a physician because you may have more than one monitor. So I'm looking over at the patient, but the camera's over here, so it creates this top look where I'm not really looking at you, or I'm trying to enter information into the infamous electronic health record, and it doesn't really look like I'm paying attention to you. So people felt very disconnected. They felt that there was the potential for errors. They felt that providers were less attentive, that there was difficulty in establishing a relationship, and that they were, importantly, unheard and neglected. There was another study, and this one I think is fascinating. These aren't the pictures from the actual study, but they're actually from an open access file of shots, and it captures the essence. How many people feel that there's better eye contact with the image on the left? How about on the right? Okay, so you are in perfect sync with what this study found. So what people found is that most people, I think about 87% of the people, felt that you had better eye contact if you were in the image on the right-hand side. Sorry, and what people found, let me make sure I'm doing this in the right order. Sorry, I'm seeing the previous slides, confusing me. So if you're looking directly at the camera, the perception was that you were happier, that you were warmer, more approachable, again, more confident, maybe more competent, more trusted, better rapport, more interested in what you had to say. If I'm not looking at the camera, I'm shy, I'm timid, I'm not forthcoming. I'm distracted by something else. I'm not focused, I'm not engaged, and I'm not giving you my full attention. So again, it makes intuitive sense, but this is what the research has actually found. Now I'll go back to those virtual backgrounds again. There is a certain perception that you're not to be trusted if you're using a virtual background. because what's really going on behind you. And again, it's that concept of the door. I don't know who's in the background. I don't know what's going on within that space. So again, we're setting up different perceptions depending upon, how we're doing things. So interestingly, we talked about that from the patient perspective, or from the clinician perspective of a patient potentially, and what they might be perceiving. And think about it in the context of mental health. If I'm looking at somebody who has a camera gaze that's a little bit off, I'm potentially thinking that there's something going on that might not actually be going on. So again, important to think through. The camera versus screen gaze, so physicians that are looking at the camera are seen as being more trustworthy, more caring, more focused, more inspiring of confidence for patients, less patronizing, less robotic, and there is the potential for more involvement in care, a higher level of security, feeling more safe, more comfortable, and being physically and psychologically closer to the physician. So interesting that we have, just by how we're looking at the camera, become a little bit of an issue. There are some challenges though, so I want to talk about where we might be headed. Some of this is for real and some of this is maybe. So if we look at that camera gaze angle, the challenge is if I'm looking at the camera, that's not necessarily a natural thing to do, because now I'm not looking at you. If I'm a clinician and I'm focused on looking at the camera, I'm not seeing what's actually happening with the patient. So there's two solutions. One is just the physical distance. So the image on the left is a project that was developed between Steelcase and Philips, and it's called Atlas, which is accessing telehealth through local area stations. And this was set up in Veterans Administration's community-based places, similar to the library, where people could go to get telehealth services. And what you can see is it's an entire room, so you're fairly far away from the camera. You have some of these camera gaze angles resolved. You can see the blue. Everything is set up in a very controlled way. The second is a brand new project. This started out as called Project Ghost last year, and it was unveiled this year called the Ocular View, and this is between Steelcase and Logitech. And what's interesting here is they've started to use the technology in a different way. So they've built this pod where you can have one or two people, and you're looking at a life-size person within the room, and it is using teleprompter technology. So it's using mirrors to project the image so that you can look forward at the camera and have that correct gaze angle and have the privacy of being in a space. And they've just started testing this in a location at a rural hospital in the Midwest in the United States, where people can't travel for a couple of hours to get some of the care that they might need. So it'll be interesting to see how this actually works out. But these are real solutions that are being developed, and really companies that are thinking through what are the implications of the built environment and how do we make sure to take that into account. So just some development sketches. The last thing that I just want to close with is this next generation of digital health, and not just being about some of the basics that I've talked about, but really trying to understand the interaction of AI, the interaction of the technology, and all of the things that we've been talking about. And there's this group in Italy, Spoladore, and many colleagues. There's actually one architect on this team of 10. Yay. And what they ended up doing was a systematic literature review around smart waiting rooms. And what they found was there was nothing about the built environment in any of the studies that they included in the review. And yet they all knew the built environment has something to do with this. So they really started looking at what is this interaction between the digital world and the physical world, and how do we start to look at that? And what they've proposed is a system where you can start to diagnose mild cognitive issues by using a virtual environment and AI. So you can come into the waiting room, you can put on these virtual goggles, you can customize the space depending upon the characteristics of the patient. You can start to take some baseline measurements. That can be used for the future. You can use AI to try and understand, are things different than the last time? Let's start to look at a longitudinal issue. But they also use gaming, where you may ask somebody, go find these 4 objects in this virtual environment and bring them back with you. And then you take the goggles off, you have another few minutes, you put the goggles back on, and now you have to put those elements back. So again, for somebody with mild cognitive impairment, you can start to track how hard it is for somebody to put the objects back. And that can be done anywhere. It doesn't just have to be in a remote waiting room. So I think they were really proactive in saying, you know what, we didn't find anything about the built environment, but how do we blend physical and digital and really try to anticipate what might happen in the future? So there is a huge market that is still happening in telehealth and telemedicine. There are projections of pretty incredible growth over the next few years through 2030. And I think what people are really looking at is, you know, how is the technology advancing this, the platforms, the apps? But I think if we're really going to future-proof how we're providing digital health in the future, we need to think that all of this happens somewhere. There is always a space involved. It's just a question of how that space is being used and how the space helps or hinders. The Joint Commission just came out with July 1st telemedicine standards. I asked for the advance copy. I didn't get it. I watched a webinar to see what they might have in it. There is no environment of care because it's technology. There is always an environment of care. So let's not forget that. Telehealth's not about the technology, it's about the people. Thank you.